Okay, so today we're going to talk about the neurobiology of OCD. We're also going to talk about some therapy options and treatments for OCD. So this is the brain, right? We can all agree on that. And this is the view that we're looking at. So this is the side view. So it's as if the person's looking that way. So this is the front of the brain, what we call the frontal lobe. This specifically in the very front of the brain, we call the prefrontal cortex. Underneath the prefrontal cortex, in this area right here, is an area called the orbitofrontal cortex, and that'll be important in a second. You can see this is the temporal lobe right here. This is the cerebellum, and then the brainstem then becomes the spinal cord as it goes through the foramen magnum at the base of the skull. Okay, so this is the orbitofrontal cortex. This is that part right here in the bottom that I was telling you about. It's part of the frontal lobe. Okay, so the orbitofrontal cortex is just like a subdivision of the frontal lobe, specifically a subdivision of the prefrontal cortex, which is part of the frontal lobe. Okay, so of course anatomy has to be very, very complicated. So we have like the different lobes of the brain, right? So we have like the temporal lobe and the parietal lobe and the frontal lobe and the occipital lobe. But the frontal lobe, so this is the frontal lobe, is divided into a bunch of different parts, and one of those parts is the prefrontal cortex. And within the prefrontal cortex, it's also divided into many parts, and one of those parts is the orbitofrontal cortex. So the orbitofrontal cortex is the bottom part, which is right here, and this is a view looking from below. So if this is the sort of brainstem here, becoming the spinal cord, we're kind of looking up at the brain, all right, from below. And this is like the front. So this is the front, and this is sort of the back, right? This area on the bottom of the frontal lobe is the orbitofrontal cortex. Now, this is a very important structure in OCD. And why is it an important structure in OCD? Well, I'll tell you in a second, but it's a very important structure just in anxiety and in decision-making in general, because what happens is, let's say you are leaving your home, you're going to work, and you get in your car, and you're driving to work, and you're thinking about all kinds of stuff, and all of a sudden, bam, you think about, oh, did I lock the door? When you think about that immediately, when you think, oh, did I lock the door? Bam. The orbitofrontal cortex sends a signal saying something isn't right. There's something not right here, okay? And that signal that something isn't right is important, because how we manage that signal ultimately determines whether we can just be like, okay, well, no, you know what? I've never not locked my door. And you know what? Even if I didn't, there's a burglar alarm installed, so it'll be fine, right? That's going to determine whether we just keep going with our day, or it's, nope, I'm going back because I absolutely need to make sure that the door is locked. And I'll sort of try to explain the best I can what we know about the neuroanatomy and neurophysiology. So the orbitofrontal cortex is very much involved in integrating sensory and other information to determine what the reward is going to be. It controls our impulsivity, right, and our decision-making based on what those rewards are going to be. It's viewed as the highest integration center for emotional processing, and it plays a role in our ability to adapt to conditions that are changing in our environment. So it really is important in our ability to sort of be flexible in terms of our, accommodating environmental changes. We know that experimental lesions in monkeys in this area causes them to have impairment in their ability to learn new things based on reward contingencies, right? So in other words, when we lesion the orbitofrontal cortex in monkeys, I don't lesion them, but when neuroscientists lesion them, monkeys have a very hard time learning something new based on reward. They also exhibit an absence of emotional reaction to their environment. What we know is that, or what we think, is that the repetitive rituals, those compulsions that occur commonly in OCD and other related disorders, as well as the obsessions and aggressive behaviors, are predominantly due, at least in part, to serotonin deficits in this area of the brain. But again, we can't be that simplistic and say that just one area and one neurotransmitter is responsible for this complex behavior. This is not the full story by any means. And there's many other structures in the brain that are involved in this. But based on what we know now, at this point, we do believe that there is something to do. There's something about serotonin in this part of the brain that could be dysfunctional. Okay. Now, this is from Nature Review in 2014. It's a good summary slide of what we see in terms of how OCD manifests. It's a good summary slide, because what it shows us is that OCD is not just a environmental problem or environmental induced disorder. It's not just a genetic disorder, it's both. And what I mean by that is, typically individuals who have OCD probably had some genetic predisposition or vulnerability. So they had the genes that could potentially develop into OCD. But whether or not those genes ultimately lead, or whether or not that vulnerability ultimately manifests as OCD, depends on whether or not there's environmental stressors that then bring out the disorder, if that makes sense. So in other words, it's a combination of vulnerability in your genetics and the environment that ultimately come together and alter the chemistry and functioning in our brain that then leads to these very complex OCD behaviors. So again, this is the brain, and this is the side view. So this is, the view that we're looking at, and this is sort of, we're looking this way. I'm just going to quickly point out a few structures, because it's going to be important in a second when we talk about how this stuff works in terms of therapy. So this is the prefrontal cortex that we talked about before. This is the front of the brain, right? It's part of the frontal lobe. Again, the orbitofrontal cortex is part of the prefrontal cortex, and it sits sort of in the bottom right here, right? The amygdala is that part of the brain involved in fear and worry and emotion, and sort of eliciting that kind of anxiety and panic reaction in all of us when something goes wrong or we're scared. And we'll talk about that in a moment. Nucleus accumbens is this area here that's involved in reward and pleasure and reinforcing type behaviors, very much important in addiction. Corpus callosum, it's basically the neurons neurons are basically like telephone wires. You can kind of think of them like telephone wires. They have like this little cell body, and they have these like long projections, which then connect to another neuron that then has a long connection, goes somewhere else. These wires, if you will, telephone wires, are called axons. Okay, and then the axons that connect different neurons are very, very long, and they travel in bundles. So you have like a whole bunch of axons that are traveling in this like bundle, kind of like a cord almost, that has a whole bunch. Now, so what the corpus callosum is it basically is a bunch of these wires, these telephone wires, that are connecting the right and the left side of the brain. And so if you really kind of zoomed in, you kind of see these little dots, if you will, because we're cutting the brain in half, and this is sort of the cross section, right? So these are like the telephone wires that are coming at us to connect the left and the right side of the brain. So that's the corpus callosum. Cingulate is just this part of the cortex. The striatum, which, sorry, I'm covered up here, but the striatum is a combination of this structure, which that each of those are the caudate putamen, but together we call it the striatum, and it's important because it's involved in OCD and other types of habitual behaviors. That's the midbrain, the pons, and the medulla oblongata. All of them together make up the brainstem. You don't need to remember any of this. I'm just showing this just for anybody who's interested. Okay, so the orbitofrontal cortex, like we had talked about, that area that's like the something is wrong alarm, right? When you're kind of going about your day and then all of a sudden something happens and you're like, huh, something's wrong. The orbitofrontal cortex starts firing. And the orbitofrontal cortex and the entire frontal lobe is connected to a whole different regions of the brain, right? Like I told you, they're like neurons are like telephone wires. They're like connected all over the place. And there's a circuit in the brain involving the orbitofrontal cortex, the thalamus, which is just like another area of the brain that's like a relay station, right? It's like a sorter, like the neurons have to sort of stop there and kind of send their signals and tell the thalamus, what's going on. And then the thalamus is like, oh, great, okay, we're sending it out this way because this is where it needs to go. Obviously, this is very simplified and they're not actually communicating that way. But the thalamus, the orbitofrontal cortex and the thalamus have connections. The orbitofrontal cortex and the striatum have connections. And they're reciprocal, so they're back and forth. So these are all connected to each other, in other words, all right? So if we were to put connections between all of these, we would just connect all of them. So there's this circuit, and this circuit is important because this is the circuit that's involved and goes awry in OCD. So the theoretical basis of OCD, this is again from that same Nature Review article. This is sort of the cycle of OCD. You have a stimulus, whether it be internal or external, right? So this is the stimulus. And the stimulus can either be an environmental trigger, it can be a thought, internal thought. It causes distress and anxiety. We then, we obsess and think about this intrusive thought or urge or feeling or image or whatever it is. And this again causes more anxiety, and we just kind of keep building up that anxiety, right? Kind of going in this loop like this. And then as a way to manage that anxiety, we start doing sort of ritualized behaviors like compulsions. And what that does is it temporarily relieves our anxiety, but it's not, it reinforces and sort of relieves it a little bit, but not quite enough. So then you have to keep doing it and you just get stuck in this loop, right? So these are the sort of loops that I'm talking about, right? And this is sort of the basis of the obsessive compulsive cycle. So neurotransmitters implicated in OCD pathophysiology: serotonin, glutamate, and dopamine. Like we had talked about just now, the corticostriato-thalamocortical circuit. You can say that 10 times at the next cocktail party. You'll be looked at as crazy, probably, but this is the circuit that is very much involved in OCD and many other disorders. But we know that hyperactivity in the orbitofrontal cortex, that area again, that's like something's wrong, it's overactive in OCD. And the caudate nucleus, which is a part of the striatum that we had talked about, is also overactive. The main neurotransmitter in this circuit, and the main neurotransmitter in the entire brain, right, is glutamate. If you hang around psychiatrists for too long, you may think that the only neurotransmitters we have are dopamine, serotonin, or norepinephrine. And it's actually, in fact, glutamate and GABA are the most abundant neurotransmitters and make up the most of the neurotransmitters in the brain. So glutamate is very much involved. And this is probably why now we're seeing that some of our glutamate agents like ketamine and some of our treatments like TMS, for example, are beneficial for patients because we're ultimately changing the connections or the signals between different areas of the brain. And glutamate is a primary neurotransmitter that's the most abundant in the brain. And we also know that there's increased glutamate levels in the CSF caudate and orbitofrontal cortex in OCD patients. So the etiology and etiology just means like the cause, and the pathophysiology still remain unclear. This is all really theoretical based on imaging studies and animal models, but it's likely, like I said, a combination of environment, biological factors like genetics and like family history and maybe certain medications or drugs that were used, behavioral factors, psychosocial factors, how you were raised, what that environment was like, the behavioral factors, right? Sort of what behaviors were you displaying that ultimately led to changes in your brain that then led to OCD. So the obsessive compulsive disorder treatments, we know that the SSRIs are the selective serotonin reuptake inhibitors. And the selective serotonin reuptake inhibitors, or the SSRIs, are like Prozac and Paxil and Zoloft and Celexa. And that's the first line treatment for OCD in terms of medications. But therapy is vital. In other words, if we just treat OCD with medication, we're probably not going to get as good of a response, or we're not really going to get to where we want to be in terms of treatment. We really need that therapy component. We need that additional therapy. And we know that the combination of medication and therapy together lead to outcomes that are better than either alone. All right. And if you had to choose any of them, I would choose therapy over medication. However, some people, like myself, who in the very beginning were sort of skeptical about medication, came to realize that medicine is actually very, very helpful. And medication, what it can do, if anything, is help you reduce those symptoms enough to where you can participate in the therapy. Because sometimes if your symptoms are so severe, doing the exposure response prevention type stuff and the CBT and all of those therapy modalities, which are great, would be very hard to do if you're just constantly anxious and you're very, very symptomatic. Clomipramine is an old tricyclic antidepressant. It's the most serotonergic of the tricyclic antidepressants. It used to be the gold standard for OCD, but because of side effects and concerns about cardiac effects, it's not used as often. But clomipramine is a very good medicine for OCD. The brand name in the United States is anafranil. Other therapies, naltrexone is a great therapy. I use it. It's off-label, but naltrexone is a opioid antagonist. It's used for alcohol use disorder, and it's used for opioid use disorders. The theory behind why I think it works for OCD is that I think of OCD as somewhat of a addictive type disorder, in that we get sort of stuck in these cycles because we're trying to reduce our anxiety by doing or performing these rituals. And if we're performing these rituals and we're trying to reduce our anxiety, it's like we get a little bit of reinforcement, right? A little bit of relief from doing these sort of compulsive acts. A little bit, right? Until we do them again. But if we can reduce that reinforcing effect when we do the compulsive behaviors, perhaps we won't be performing them as often because we're not getting that relief. And it's interesting because in the patients that I have tried naltrexone in, they have had robust responses in the compulsive type behaviors. But naltrexone just by itself probably isn't going to be enough or adequate for treating obsessive compulsive disorder. But it's a good sort of add-on treatment, I think. ECT, electroconvulsive therapy, psychosurgery, deep brain stimulation, ketamine, glutamatergic agents, TMS, transcranial magnetic stimulation, There are a bunch of new modalities that are coming out for OCD, and it's great. But the SSRIs are the first line in terms of medication. And then the SNRIs, which are like the Cymbaltas and Effexor, those two medications you can also use in OCD, but they're not considered the first line treatment. So now I'm just going to briefly talk about cognitive behavioral therapy. So cognitive behavioral therapy, as I sort of discussed a little bit in the very beginning, is this idea that our thoughts, behaviors, and feelings are sort of in this web, if you will. They're sort of like interacting with each other in very complex ways, in that any one of these affects the other two. So the idea here is that it's very difficult to change how we feel, right? If you've ever tried to tell yourself not to be anxious during a time of anxiety, it usually doesn't work. I mean, I don't know, but when I'm anxious about something and then somebody says, just don't be anxious, it's like, oh, got it. Okay, perfect. Yeah, now I'm not anxious. That doesn't work, right? So the idea here is that we can change our thoughts and we can change our behaviors through practice and through exercises. And that's the idea behind doing the thought record and the exposure response prevention type exercises. Because if we can change our thinking, we can ultimately change our behaviors, then we can change how we feel. And ultimately, that's what we want, right? We want to feel better. We don't want to be feeling anxious all the time. We don't want to be feeling these things, this negativity all the time. So this is the idea behind cognitive behavioral therapy, that if we can sort of change our automatic thoughts that we have, and we can sort of change and alter some of our behaviors, these two things are ultimately going to change how we feel. So this is the thought chart. Everyone has one of these. You should have downloaded this. If not, it's in day one. The idea here is you're going to go through this as many times as you possibly can. Even if you go through it once a day, just once, that's great. I'd say the biggest reason why these types of therapies don't work is because they can be time consuming and they can be exhausting and they can be overwhelming for some people. And it can just kind of get in the way. People think, it just doesn't, this does not work. This just doesn't work. The problem is that it does. It works. But you have to really practice it and put the time in. Just like anything else in life, practice makes perfect. Now, in this case, practice isn't going to make perfect, but practice is necessary in order to start feeling better and start breaking some of these habits. And so what we'll do is I will go through this thought chart in the next, let me remind me later. Okay. In the thought chart, we will do this together probably tomorrow. And this is the feelings chart, which you have. And again, we are going to review this tomorrow in relation to the thought record and how we're going to use it as we move forward. Exposure response prevention is just another modality that is basically under the umbrella of cognitive behavioral therapy. And exposure response prevention therapy really does, so what is this? What is exposure response? Why does this work? Why do we think this works? The idea here is that the amygdala, this area of the brain, right, that sort of worry center, is very sensitive in people with anxiety disorders. In other words, it's activated very quickly and overly activated, which then leads to excessive exaggerated anxiety response. So in a normal person who doesn't have, when I say normal, I mean like not like we're not normal, I'm saying like a normal person who doesn't have anxiety or is able to manage their anxiety, their amygdala doesn't light up nearly as much. And what I mean by light up is like activate nearly as much or as quickly or as often as somebody who does have significant anxiety. And the reason for this is very complicated, but the very basic idea, okay, and this is, if you're a neuroscientist, you may have a heart attack by me saying this. You may have a heart attack just by listening to this lecture, but the simple explanation is that the frontal lobe, or that area of the brain that we talked about that has the prefrontal cortex and the orbital frontal cortex, is basically sort of like telling the amygdala through various means, telling it, literally communicating with it, saying either activate or don't activate. In general, the frontal lobe is inhibitory. All right, it sort of it tells the amygdala, okay, hold on a second, like you're getting really, really anxious about this, but let's reason this through. Let's not get just not just to jump to conclusions here. Let's think about this. Let's put this on the stand and let's debate this, because I don't know that your anxiety, it's just a little too much for this situation, right? So that's what your frontal lobe basically, in general, along with the hippocampus, which is that memory part of your brain, they are really responsible for quieting down the anxiety of the overactive amygdala. All right, and so the idea here is we're trying to engage your frontal lobe as much as possible, and that's the cognitive part of cognitive behavioral therapy. We're trying to reason out, okay, what are my thoughts? Are these thoughts realistic? Are they not realistic? Do they make sense? Just sort of, thinking about your thoughts and sort of putting it out there and objectively looking at your own thoughts. So that's what sort of this idea is with cognitive behavioral therapy. Now, with exposure response prevention, what we're doing is we're basically exposing ourselves to something that's very anxiety provoking. So we're putting ourselves in a situation that really makes our anxiety go through the roof. And by doing this over and over and over again, what we learn is that every time we do it, we reason through it and we quiet down our amygdala. And over time, our amygdala starts learning, quote, quote, learning, oh, all right, so next time this kind of a thing happens, this is not that bad. There's no bad consequence, right? This is okay. So over time, your amygdala starts to learn that it's okay because your frontal lobe and these other structures are influencing it over and over and over and over and over again, telling it it's going to be okay, it's okay, it's okay, it's okay, it's okay, it's okay. And so that's why we do the exposure response prevention. We do the exposure. We don't, we put ourselves in a very anxious, anxiety-provoking situation. We don't respond to the compulsions or any of the behaviors that we use to avoid any of that anxiety, right? And we realize, hey, things are okay. And over time, and this is very difficult, right? So it takes a lot of practice, and it can be overwhelming. It can be very discomforting, but over time, you will quiet down your amygdala, if you will, and you will start to feel, wow, I don't feel as anxious in this situation that I was before. And then this is the exposure response prevention table that we will also go through tomorrow when we talk about the thought record. So the problems with OCD treatment currently, only 20 to 30% of patients have significant improvement. 40 to 50% of patients have moderate improvement. 20 to 40% of patients do not respond or get worse. The higher doses of the SSRIs or the selective serotonin reuptake inhibitors are required to treat many of the anxious symptoms associated with OCD. So unfortunately, in OCD and many other anxiety disorders, compared to depression, you need a higher dose of an SSRI. And the problem with higher doses of SSRIs is that you have a higher chance of side effects. So this leads to noncompliance. So the last thing I wanted to mention is that CBT and exposure response prevention are very effective therapies, but they can be very, very overwhelming and time consuming. But if you do them, if you're patient and you're persistent, you will persevere. But it takes sort of discipline and repeating these exercises again and again and again until you can really master it. And then this is just a list of all the other OCD-related disorders, which we aren't going to talk about, but many of these disorders you'll see here often exist with OCD. And that's it. Thanks for listening, and we will see you tomorrow.